Okay, so the ultimate question that we want to answer in this talk is spinal endoscopy going mainstream. You can see my disclosures here. And I've been particularly asked to describe the process for patient selection, evaluate when to use endoscope or microscope, and also to identify advantages of the endoscopic over microscopic surgery and when to choose which one. So first of all, we know that there are many different ways how you can decompress neural structures. And what you can see here, either with fusion and laminectomy, or what you can see around the left side, is quite invasive for the patient and has a number of disadvantages. And this is why I think we would all agree that the microscope over the last years and decades has been established as a gold standard, huge advantages, smaller skin incisions, earlier patient mobilization, and all of the advantages of MIS surgery. What I'm talking about is, so to speak, the next step, that of full endoscopic surgery. And you can see here a view into our operating room. We're quite spoiled with nice 4K screens that directly deliver images from out of the patient's spinal canal onto these screens, and everybody can join the surgery directly. Perhaps let us establish what we're talking about, because sometimes these terms are used somewhat synonymously. We're not talking about micro-endoscopic, we're not talking about any tubular systems, and we're not talking about endoscopically assisted. What we're talking about really here is that of full endoscopic surgery. So you can see here, this is how we do it. We make a small skin incision, 6-7 millimeters skin incision maybe. Like I said, everything is projected through these optical fibers onto large HD or even 4K screens nowadays. You have perfect visualization of the neural structures, which makes this procedure, in my eyes, very safe. And at the end of the surgery, you can finish the surgery with just one single stitch suture. And just so that everybody knows what we're talking about, we've got a number of different endoscopes that we can choose from in accordance with the underlying pathology. So you can see this is what an endoscope looks like. We've got these optical fibers in here. We've got working channels, 3 millimeter working channel for the cervical pathologies. The middle one here I predominantly use for lumbar soft disc pathologies. And then the largest one, where we really have to remove a lot of materials, is that with a 5.5 millimeter working channel, which you can see here on the right. And also, depending on the underlying pathology, there is no best approach. It always depends on the pathology that you're trying to address. We have transforaminal or interlaminar approaches. To be perfectly honest, these approaches don't vary that much in my hands in comparison to the microscopic techniques. So my preferred approach is actually that of the interlaminar approach, which I will show to you just now. And we have all kinds of instruments. We have burrs, we have sharp burrs that you can see here on the left. We have diamond burrs, which are a little bit, which are not quite as aggressive. You can also use these to address potential bleedings from the cancellous bone. We have scissors, we have Kerenson rongeurs on the left side. And this is also not just the skin incision. We heard this in the previous talk. Like on the left side here, you can see this is a case of lumbar disc herniation. You really only need to create a small 2 to 3 millimeter hole into the yellow ligament, just enough that you can get in with your endoscope. You can leave the rest of the yellow ligament intact, which is also part of being minimally invasive. And then hopefully you can only do a sequestrectomy. On the right side, you just saw images of spinal stenosis. I will show that to you in another video just now. You really have great visualization. This is an image, central spinal canal stenosis and decompression and recess decompression. You can see the nerve roots here. We're really working within very close proximity to the neural structures. Once you have done that, you can also go over the top, and you can also decompress the contralateral side. You can see here either with scissors or later on also with Kerenson rongeurs. You can see here by rotating the optics, the 25-degree angled optics, you get a good visualization of the tip of your instruments, which you need so that you always see what you're doing. And this is also one of the tools to make this procedure very safe. Cervical lateral disc herniations, you can also treat that endoscopically. I know there are surgeons that also do anterior cervical pathologies with an endoscope. To be perfectly honest, this is nothing for me. I'm too scared of vital structures here, esophagus, just to name one of them. But full endoscopic posterior foraminotomy was one of the procedures which I saw, let's say, about 15 years ago. And it was one of the most elegant surgeries that I had seen at the time, and which kind of convinced me to go endoscopic. And you can see this case here. And the surgery, this is just a quick video just to show you what we're doing. Again, same principle. We are demonstrating, we're exposing the neural structures. You see the exiting nerve root here. You go underneath the nerve root, and then you can take out all the disc fragments. And at the end of the surgery, you can see the cervical nerve root fully decompressed, it's pulsating, you can move it. And then you can finish the surgery with just a small single stitch suture. What I particularly like here is, that bleeding sometimes can be an issue when you address these pathologies with a microscope, but this is not an issue when you work with full endoscopic technique. And also you can see it was quite a strong lady. You can finish this surgery again with just a single stitch suture. And this is also a video. What you could also do is, you can see here a disc space preparation for an endoscopic interbody fusion. So you can see here that we have shavers, all kinds of instruments to really clear out the disc space, and then you can prepare the disc space to do an interbody fusion. So this is what is technically possible. Now, I have been asked, does this mean going mainstream? There is a nice literature review from Michael Meyer. What can you do in a full endoscopic technique? You can do soft disc pathologies with sequestration, without sequestration, synovial facet joint cysts. You can do revision cases. Basically, you can address all kinds of pathologies that you can also address with a microscope. There's just one other factor that comes in here, which is that of the learning curve. And there is no doubt about that. You need a long, long time, even when you are an experienced surgeon already, for a number of reasons: the handling of the instruments, the anatomic orientation. So there is definitely a learning curve. And that's why the question of going mainstream is not so much if the technique is ready to do so, but it's much more where is the surgeon at the time of his or her learning curve. And do you feel ready to already go for and address spinal stenosis, over the top decompressions, or do cervical cases? But technically speaking, all of this is manageable with an endoscope. So what are reasons if we already have a microscope? So like I said, my background is microscopic. I've grown up with a microscope. So why should we expose ourselves to another learning curve? And why should we go endoscopic? First of all, we've always been asked to provide literature. This is one of the latest literature, meta-analysis, which has been published. Large number of patients, over 4,000 patients, data from 11 RCTs and so on, comparing the microscope versus the endoscope for lumbar disc herniation cases. And the endoscope was either equivalent in the results or superior. And that's why the authors from the study concluded that endoscopic discectomy has the potential to take over from microsurgery as a potential next generation gold standard treatment. What you can also see here is the visualization. The visualization with the microscope, which you can see on the left, is very, very good. But at the end of the day, you zoom in, and whereas with an endoscope, you're working within extremely close proximity of the neural structures, let's say 1 or 2 centimeters, and we have 25-degree angled optics, which gives you a very large radius of visualization. So the visualization with an endoscope is really flawless, and it is actually somewhat the next step when working with these kind of pathologies. You know, from the WHO, repeatedly comes back to this problem of increasing number of obese patients. And I can tell you now that I am so happy that we have something for these either very strong candidates or very obese patients. Because for me, it doesn't really make a difference. It doesn't make that much of a difference if the patient is 50 kilos or 150 kilos, because at the end of the day, you can pretty much do the same surgery with an endoscope through the same 6 to 7 millimeter skin incision. And that's when this technique becomes very elegant. And then you can do surgeries monosegmentally, or as you can see here, you can also do multi-level cases. Obviously, you need to be a little bit further in your learning curve so they don't take too long for a single segment. But you can see here, you can do advanced spinal stenosis cases, not just easy cases. This is a case of 4-level over-the-top decompression. And then this is what the wounds look like only 10, 14 days after the surgery. And this takes me to my next slide. I don't know, all of us, how many conferences have we visited where we talk about this huge dilemma of infection or wound healing problems? These numbers are rising, but this is one complication which, because of only these small skin incisions, 6, 7 millimeters, they really always heal. And I would say you can almost eliminate the risk of infection or wound healing problems. So if we completely changed to endoscopic, this would have a huge impact for millions of patients on a global scale. You can still have other complications. You can have complications of recurrent disc herniation. You can have a dural lesion. You can have post-operative epidural hematoma when you decompress the spinal canal. But with respect to infection or wound healing problems, you can almost eliminate this risk, which from my point of view has a huge impact. I think we will see more and more surgeons going endoscopically, and other colleagues have done that already. You can see here from knee, whether that is knee, hip, or shoulder surgery. And we will see the same beneficial effects that we saw when we went from open surgery to microsurgery. And for these exactly the same benefits of MIS surgery, we will see a further reduction in the invasiveness when we go endoscopic. So now the question is, when we talk about going mainstream, when should you use the endoscope or when should you use the microscope? And that is a very, very individual decision depending on where you are in your learning curve, and that will change over time. So for me personally, but this is a slide that really only applies to me personally, 15, 18 years ago, I did 100% of my cases microscopically. Nowadays, I do 80 to 90% of cases with an endoscope because we can further reduce the invasiveness of the procedures. I really like it in posterior cervical. I really like it when I have to treat obese patients, and because I can really eliminate the risk of infection or wound healing problems. And I basically use it for all cases. But there are some cases where I still feel more comfortable to use the microscope, but that nowadays is the minority of the surgical interventions for me. Basically, the few remaining cases then, I think what we have to establish too is if you work in a very large clinical setting where you have to bring new and upcoming surgeons to a level where they can do emergency surgeries at 2, 3 o'clock in the morning, you still need the microscope because the learning curve is so much faster. It will take too long if you teach every one of them how to use the endoscope. So that's why I think there is still a place for the microscope in the coming years. For example, also maybe in cases where you need to do a revision surgery, or basically where you need to go the next step in our in the cascade of invasiveness of our surgical armamentarium. And then there are cases where I choose extrapyramidal lumbar disc herniations, for example. There are some cases where I really like the endoscope. Some cases where I'm glad that I chose to do this microscopically. So there are some cases in between. But like I said, this very much varies from surgeon to surgeon. It's a very individual decision of where you think how you can address the underlying pathology in the best possible way. So for every surgeon, there will be somewhat a micro-endo blending, and you will see that with more and more experience with endoscopic technique, you will probably be doing more cases endoscopically, which in the past you've done microscopically. But you need to have patience. This is an investment into a new and innovative technique. And this technique in every surgeon's hands needs time to grow. So if you think that you're going to change to endoscopic technique because now you can do every case in 15 minutes, this will not work. Later on, there are cases that you can do in 15 minutes, 20 minutes, but this is not the intention when you start learning this technique. In the beginning, it might even take longer than with a microscope, where obviously you've done thousands of cases in the past. So thank you very much for your invitation to everyone, and it's an absolute great pleasure and honor to join this fantastic meeting. Thank you.
Superbly done. Please accept our applause virtually, Christoph. Hopefully we'll be able to welcome you in Seattle in the future and see your hands and magic applied in our cadavers in our beautiful labs. I have an economic question first. You're obviously the head of a very major department, and your bosses are very economically motivated. Obviously, it's a large industrial, almost Aktiengesellschaft or ownership group. So they want to see money. They want to see a return on investment. Here in this country, endoscopy has been marred by disposables, which is a real problem. Disposables, which are basically cost factors. So for us, endoscopy in our economic model only works if we have it in an outpatient center where the patient can pay a surcharge or the hospital can translate the funds demands directly. In a hospital, we are covered by DRGs. We can't afford this. How do you make this equation happen in Germany in your center?
You're absolutely right. There are so many factors that influence us and our decisions. And obviously the reimbursement is one of them. And that's why, when we look, for example, the time of hospitalization for the patients in the US, for example, patients, when you do a procedure like that, patients, generally speaking, would be able to go home same day. Here in Germany, because of our reimbursement system, the patients have to stay for 48 hours. Otherwise, we're being deducted a substantial amount of our reimbursement. And this is sometimes when you look at international publications, US surgeons tend to think, why are patients staying so long in countries like Germany, because the time that they stay in the clinic is so much shorter in the US. But here in Germany, we're lucky. The reimbursement is pretty much the same. The time that patients stay in our clinic is a little bit faster even for endoscopic patients than for microsurgery. And there are so many factors that also play a role here. Factors just like infection or wound healing problems. In Germany, if you have one infection, every single following revision case you basically do for free. So that also is part of of decision making. This kind of makes the endoscopic surgeries a little bit cheaper because you can basically almost eliminate the risk of infection or wound healing problems. So here, overall, I would say that the reimbursement and what you can get is pretty much the same for endoscopic and microscopic procedures.
Great. Rod, why have you not started doing spinal endoscopy?
Maybe just one additional comment.
Go ahead.
Something that's also important, I think, is, if you look at, there's a lot of competition in a city like Munich. And you find a lot of surgeons and neurosurgeons that are doing very experienced with a microscopic technique, but patients, they really demand this. This is also part of, like a business decision, and there are not that many surgeons that are really experienced with going endoscopic. So this is also a part that maybe also, the patients demand it. I think that patients, the image is, it's that this kind of surgery is not so invasive, when you only have a 6-7 millimeter skin incision, as opposed to when you really need to make a larger incision. So I think that's also something the patients really like it.
I think Roger probably would be more qualified to talk about endoscopy, but I agree with, all the comments you made as far as, I think it's an evolving technology. And I think, it's only going to get better as we use it more. What do you think, Roger?
I don't want to, I know you guys are probably a little bit delayed now, but I had a quick question. Christoph, that was a really nice presentation. So my question or my potential criticism, if you look at the spectrum of spine surgery, the low complexity is the lumbar disc herniation, and then you go over the fusion, the spondy, multi-level cases, complex deformity. The technologies that have really taken off, they were initially criticized, but then at the end, I think there's a lot of proof now that they're really taking off, like navigation, robotics, tubular surgery, lateral surgery, initially for indirect decompression and now for deformity correction. Those are all technologies then slowly kind of covered like the whole or a majority of the spectrum. Now with endoscopy, what I see is that you're always in that all the way on the left side, the low complexity, the lumbar disc herniations, maybe a lumbar stenosis case. So my worry is just that the learning curve is so complex that it's never going to, and if it's never going to expand to the more complex cases, surgeons are just going to make a decision that maybe it's not worth really going through that learning curve unless you're being trained as a very, very young surgeon and you pick up all of those technologies. Where do you see it going, like in terms of endoscopy being valuable not only for low complex cases, but also for like the middle complex and the more complex pathologies?
No, I think we completely agree on that. Spinal endoscopy is not the type of surgery that you want to use when we're talking about high complex deformity correction. This is not what endoscopy is about. Endoscopy is about taking the next step in reducing invasiveness for patients with thoracic or lumbar or cervical compression syndromes. That's what it's for. Over the last 30, 40 years, we've seen the microscope. It's been around. It's been a gold standard. But, with advances in medicine, we're looking forward to taking the next step. And these are a lot of patients that we're talking about, there are a lot of patients that will benefit from this next step. That's what I think. But you're absolutely right. There's nothing for spinal deformity correction.
Right.
Great stuff. Shall we continue? This, again, is such an important topic, and we'd love to continue this debate and discussion and the intricate insights involved, and we'll hopefully have a chance a little bit later. Let's continue on with another.